Good evening, everybody. Welcome to this another session of 49th comprehensive course on echocardiography. I'm Dr. Rakesh Gupta, who's going to talk about the introduction to M mode, 2D, and Doppler measurements today in this particular class. As we would have understood last in two classes, we looked at M mode and 2D imaging, followed by a Doppler. And now we are going to talk about these measurements, what all we need in day-to-day in our clinical practice. That's what the topic as on today is. Let me move on to my slides for measurements. Well, the most important part for any echocardiography is we look at the dimensions, we look at the measurements, and on top of that, we talk of the most important part is a Doppler measurement or quantitative echocardiography in sense of measurements as well as gradients. And that's what we're going to teach you today, where that's what we're going to discuss today, the same topic. Well, there are two kinds of a measurement we should be looking at it is. One is a M mode and second is a two dimensions examinations. These are the two backbones of echocardiography for any examinations. Echocardiographic examination is performed with the objective of quantitative assessment of a heart today. Qualitative is useful, but our objective is to assess quantitative assessment of the heart. This is used for quantification of volumes, area, linear dimensions of the LV cavities. What do you mean by volumes? As we understand, if you look for a diastolic function abnormalities, we have to look at LV volumes. If you have to look for ejection fraction, then we have to look for LV function in form of LV volumes. Similarly, if you look at an area either by direct planimetry or an area by continuity equation, that helps you in coming to a conclusion that this valve is significantly normal or significantly abnormal. And these quantification, they are the backbones of any echocardiographic examination in the form of quantitative evaluations. For example, suppose you have got a mitral regurgitations. So what do we look at? We look at the LV volumes, whether the LV volumes are high or normal. We look at the linear dimensions, whether the LV cavity size is normal or dilated. Similarly, the same things are used in many other formats in day-to-day practice. Then estimation of contractile function to look for a regional wall motion abnormalities. Thickening of LV mass, that's what another important issue is. If I'm hypertensive, I need to look at what's my LV mass is. So that's what we look at it. And once we decide about abnormality, whether the LV is dilated or the LV volumes are high or LV mass is high, based on a monitoring of a treatment, based on a treatment therapy, whether these volumes have become less or they have become more. That's what this M mode 2D measurements are used for. There are certain technical considerations in the form of imaging planes. We did look at them. We look at a grayscale, we look at the gain setting, we look at the transducer frequency, then depth of the image display, and a position of patients. Majority of these things we have discussed over a period of in last two lectures. And we'll spend more time when we're going to show a live demonstration of all these things together in next to next class. Now the word come leading edge and the trailing edge. What do you mean by a leading edge? What do you mean by a trailing edge? Utilization of this particular modality is, if you do an M mode measurements, we do by leading edge to leading edge. If you do a two dimensions measurement, we are talking of trailing edge to leading edge, and that's based on optimal gain settings whenever we use these kind of things in clinical practice. Now look at this image. This is a two-dimensional image. This is an M mode or a cut section across this LV cavity with a papillary muscle on either side. If I look at this thickening of this particular image, look, this is definitely has got some width. And this width can be very well explained by looking at this anterior aortic root. And this is posterior aortic root. For this, here is a transducer. This is a leading edge and this is the trailing edge. Now look at this. This small definite width has got a leading edge as well as the trailing edge for measurements. So if I go back to this image, if I'm measuring the LV cavity size by two-dimensional echo, I'll be doing trailing edge to leading edge. If I'm doing by M mode, I'll be doing from a leading edge to the leading edge of the M mode. So in turn to say that what we look forward is, we look forward for our measurements by looking at leading edge and trailing edge. What all measurements are required in day-to-day practice? You may be a little afraid of seeing all these things together, but there are not very large number of measurements which are required in clinical practice as on today. The first most important measurement which is required in M mode is we look at an aorta, we look at an LA size, cusp separation, and knee point septal separation. And then we look for LV dimensions. Here is an M mode of a cut section across the aortic valve. Here is the aortic valve. All of us understand this is parasternal long axis view at the level of aorta. And here is a cut section across this particular part to give rise to an M mode examination. So what do we see? This is a place where we keep a transducer. So this is a part of RV free wall. So here is a RV free wall. Then comes anterior aortic root. So here is an anterior aortic root. Then comes posterior aortic root. Here is a posterior aortic root. And in between, there are two cusps are lying, right coronary cusp and non-coronary cusp. Here is a right coronary cusp, here is a non-coronary cusp. And behind the posterior aortic root, there is a LA. So this is what the LA is. Now, when we talk of measurements, we have to understand two important things. Two important things is, when is the end systole? When is the end diastole? And this systole and diastole is based on the LV function rather than anything else. If I'm talking of a systole, it means I'm talking of a LV systole, that is beginning of a QRS complex to end of a T wave. If I'm talking of a diastole, I'm talking of a diastole of LV, that is beginning of T wave, end of a T wave to beginning of QRS complex. So here is an example. If I look at a systole, systole is from this point to end of a T wave, that is systole is. And diastole is end of a T wave to beginning of QRS complex, that is the diastole of this particular image. So when we cut across this particular segment over here, what we got? We got an RV OT, that's proximal RV OT. And this proximal RV OT is, when we measure this proximal RV OT is, we always measure during early diastole. Then comes aorta. Here is a measurement of aorta from leading edge to leading edge. Then LA dimensions from leading edge to leading edge. Then AV cusp separation from this point to this point. Now, many of you ask me, why we need all these kind of things? Look, if you want to do a good amount of echocardiography or a quality echocardiography, I don't say good, I say quality echocardiography is, every image tells you something. What this image tells you? Look, if this is LV is dilated, look, this LV is almost how much? This is about 1, 2, 3, 3.5. So this LV dimension is roughly 35 millimeters. In this image, if this LV becomes dilated during diastole, it means there's something to do with RV cavity. Again, here we look at an LA dimensions. This is 40 millimeters in size divided by body surface area. They'll give you index LA size, which is 22 millimeter per meter body surface area. And third, the most important thing is look at this aortic valve opening and a closing. They are almost remains parallel with each other, whether it's opening or closing. What does it mean by? It means by that a valve is rectangular in shape. And if its severe mitral regurgitation is present, this becomes triangular in shape. So that's how these things happens when we do an M mode measurements across this particular phenomenon. I'll come down to a little bit later on. Let me take up one question from Dr. Somnath. He has raised his hand. He wants to understand something. Dr. Somnath, unmute yourself. You can go ahead.
Yes, sir. In parallel long axis view, when we are getting M mode through the aortic wall, what we have shown, how will we get the LV cavity? I think there is, I didn't get that.
Wait for a minute, sir.
Cavity.
We are still at LA. We'll move on to LV in some time.
Yes.
We have just started from a Delhi. We have hardly reached to Agra, and it takes some time to reach to Jhansi and Bhopal in some time. And
So,
it
just
time.
while getting measurements, you were mentioning that this is LV measurement, but is it about LA measurement? The last part of the M mode tracing, whatever it is, last part of the M mode tracing is LA cavity.
This is LV. So I'm not talking of LV at the present moment. I'm talking of aorta, LA, AV cuff separation, then LV dimensions.
Okay.
So let's move on to this LA measurements. Look, this LA is 40 millimeters divided by body surface area. And normal body surface area is 1.7 meters square. So if we divide 40 divided by body surface area, there'll be something like 2.2 or 22 millimeter per meter body surface area. Now in 2024, many of us, what they do is, we instead of measuring M mode, what do? We straightway go and measure our dimensions through dimensions echo. And how do we do a two dimensions echo is, we go to plex view and measure directly from a trailing edge to leading edge and then divide by body surface area of this LA. And this looks to be reasonably okay, since we are just looking at the image from a trailing edge to leading edge and do its measurements. But the caution is, when we have to measure this LA has to measure in early systole when the mitral valve is about to open, or end systole or a beginning of diastole when mitral valve is about to open, when LA is the largest in size. Correct? Similarly, if I do an M mode for LV, it will cut this LV in oblique fashion. So what we do now in 2024 is, we measure LV from a proximal interventricular septum, that's basal anterior septum, to basal posterior wall directly by M mode, both during diastole as well as systole. So we not only look at M mode, we basically look at two dimensions echo, trailing edge to leading edge, and that's what would be the dimensions of LV in measurements for diastole as well as systole. This is a measurement during end diastole, is systole is about to begin. So that's what the measurement is. Move this cursor to end of a T wave. Once this cursor, red cursor, is moved to end of a T wave, it becomes end systole, and then you measure it again. That becomes end systolic LV dimensions. Caution. The most important caution is, whenever we do echocardiography, we measure in the mid segment of the LV. Where is the mid segment? Wherever the papillary muscles are. Look, this is papillary muscles are seen. This is a mid segment of LV in plex view. So what happens? This is a mid segment, which is definitely bigger as compared to the basal segment. So whatever the measurement we are doing today in a clinical practice is, it has to be in basal anterior septum and basal posterior. Now let's talk about the values. Look, LA is 22 millimeter per meter body surface area or 2.2 centimeter per meter square body surface area. That's the maximum. LV is 32 millimeter and 20 millimeters per meter square body surface area. A very simple principle is you divide 32, make it 33. 1/3 always contract and rest 2/3 remains the ancestral dimensions. So 33 becoming 22 is like what is your LV dimension during end systole and end diastole. And it's pretty easy to remember. 33, 30, 22, 22. And of course, LA is almost the same as the aortic annulus is. We do have a chart. It's not that you have to remember everything by your inside look. This is what the chart is. So what we do in our lab is we have taken out these printouts, got them laminated, and they're lying in the table to refer to them again and again whenever we need to have their values in our circumstances. Next question is, what is a normal ejection fraction? Based on 2015 Chamber Quantification Guidelines by American Society of Echocardiography, the normal LV systolic function in males in India is, we consider in males is 52 to 72%, whereas females is 54 to 74%. So mean to say, the females are more masculine than males in these calculations. Now, moving on to the next measurement. The next most important measurement is LVOT measurement. We do it again in plaques view. Here we measure an LV, LA. Here we measure the LV. And now the third dimension is LVOT measurements. When do we look at LVOT measurement is? We look at the hinge point of right coronary cusp and the non-coronary cusp, and draw a line to join this hinge point of right and non-coronary cusp. That will give you an LVOT measurement. Although some people call it as annulus measurement. True LVOT is 2 to 5 millimeter inside from this hinge point here anteriorly as well as posteriorly, and then join a line to talk of a LVOT dimensions. This is very important. Why it's important is because if you have to calculate the stroke volume, this is what the LVOT dimensions would be pretty useful. The catch of this particular point is, how do you say this is right coronary cusp and non-coronary cusp is? Both of these leaflets should be opened up. They should be clearly seen, as you could see over here and you could see over here. And this is in early systole or a beginning of systole when both the leaflets are clearly seen and opening up. Then you measure this LVOT dimensions. And this LVOT dimension is approximately 24 millimeters with a range of 18 to 24 millimeters, where the males are a little bit more having a bigger LVOT than the females populations. Next is mitral valve by planimetry. All of us understand mitral valve has got anterior mitral valve leaflets, posterior mitral valve leaflet, and though these two are the commissions for mitral valve. How do we look at? When we do an echocardiography, they look like a fish mouth in appearance of mitral valve. This is AML, this is PML, and this is one commission, this is second commission, what we see over there. Now the question is, how do you get the best possible mitral valve leaflet in clinical practice? Now you have to understand some very important basic fundamentals. Look, here is mitral valve leaflet tips. Here is the body of the leaflets, and here is the annulus of the leaflets. What we have to measure? Not the body, not the annulus. We have to measure at the tip of the mitral leaflets. And this is what the picture is. We have a papillary muscles, then we have a mitral valve. So how do I look at my measurements in this particular fashion is, all of us knows that people, if they want to do a good 2 dimensions measurement of mitral valves, go to short axis view at aorta, Then come back to papillary muscles level as shown over here. Come to papillary muscles level and then gradually go back towards aorta. And once you start going back towards aorta, suddenly you will encounter the rounded structure at the tip of the mitral valve. I'll explain it again because that's more important thing is, look, this is plaques view. What I'm doing a cut section across this plaques view and parasol short axis view aorta. The first cut section is at the level of papillary muscles. If I come from papillary muscles towards mitral valve, whatever the first structure is seen is, that is the mitral valve area at the tip of the mitral valve. And that's what is the most important thing for calculation of mitral valve area by planimetry. And this planimetry can be done very well if you go back to your parasol short axis view at papillary muscles and then start coming back towards aorta, then you'll come across the first tip of the mitral valve leaflet, which is the mitral valve area. The classification after 2014 has changed. Prior to that, less than 1 centimeter was that severely reduced. Now, after 2014, which you have to remember in all your cases is, anything less than 1 centimeter square is considered as very severe mitral stenosis. 1 to 1.5 is considered as severe mitral stenosis, and more than 1.5 is considered as progressive mitral stenosis, where the normal range is about 2.5 to 4 centimeter in day-to-day practice. So we looked at mitral valve area by planimetry. We looked at aortic valve area, LVOT dimensions, and then coming down to the next step is calculation of ejection fractions. I'm sure all of you does an ejection fraction by what? The most important thing everybody does is by eyeballing. Well, I don't see my eyeballing doing all these kind of things. And similarly, I don't expect you to do eyeballing to come to a conclusion at the learning phase of this echocardiography. Today, when we talk of ejection fraction is, we always go to a biplane view. Biplane means we go to apical four-chamber view, diastole and systole. That's ends diastole, beginning of systole, and this is end systole. Look how much change has happened at the beginning of systole to end of a systole. So this is what the volume beginning of systole is. This is what the volume of end systole is. Similarly, we go to two-chamber view, anterior and inferior wall. Anterior and inferior wall, that is diastole as well as systole over here. So what we do, we'll go to a four-chamber view, calculate the LV dimensions in diastole, then go to systole, then ejection fraction is end diastolic volume minus end systolic volume, divided by end diastolic volume, multiplied by 100. That's what is ejection fraction in percentage. Don't get confused. This is RV and this is RA. This is LV and this is LA. This is Mayo Clinic representation of doing an echocardiography. Now, how do you do an ejection fraction? That's the most important thing in this patient. Again, we go to the QRS complex. When would be the LV maximum size? LV would be maximum size during end diastole or beginning of systole. So end diastole or beginning of systole is a presence of cursor at QRS complex in the beginning of QRS complexes. You start with one annulus, go to measurement, start with one annulus, trace along the black and white interface, go to the apex and again come back to the medial annulus and then let the joint being done by an automatic system where it is giving you LV volume during diastole, LV dimensions or LV area during diastole. If you multiply this LV area into length, it'll give you a volume. And that's what depicted over here. Length is 7.1 centimeter. Then area is 19.4 centimeter. End diastolic volume is 61. End diastolic modified volume is 61 ml. This all given by a machine. You don't have to really look for all these kind of a thing. Then you scroll your image from beginning of QRS complex to end of a T wave. You can see the image over here, end of a T wave. Same patient is measured starting from the lateral inverse, going up all the way black and white interface, then coming down along interatrial septum, and finally the lateral wall to look for the end systolic volume of LV in 4-chamber view. We do the same thing in 2-chamber view also, and then we talk of our ejection fraction. Like suppose this comes out to be 66%, this is 60%, the average would be 63% of ejection fraction in this subset of populations. What is the normal ejection fraction? More than 52 in males, more than 54 in females. And again, these are being about to modified because one of the society, the World Alliance Society of Echocardiography, recommended the ejection fraction as 57 or more for males and was at 58 or more for females. And that's what the ejection fraction is. And it is not coming to the guidelines, but certainly I'm sure it will come into the guidelines in due course of time. Yes, Dr. Somnath, go ahead.
Hello.
Go ahead, Somnath.
Sir, can you show the slide for EF calculation once again?
Here it.
Earlier one, sir. Yes, sir, this one. So in this, we are calculating the dimensions at end systole and end diastole, but the ECG marker is in both the measurements is showing at the beginning of QRS complex. How it is?
Oh, look, it's the beginning of QRS complex in this over here, and the end of a T wave in this complex over here. Okay. So this is how we look for ejection fraction. I think I'll take your questions in the end. Give me some time. So it like I do get disturbed when somebody intervenes in between. Please raise your hands, and at the end of a talk, I'll like to take up all your questions, and I'll take as much time as you want. Take a lot of time. My request to Dr. Darshan, please mute your mic.
So within that, so why should we go? ಎಲ್ಲಿಂದ ಬಿದ್ರು ಸುಮ್ಮನೆ ಗಾಡಿ
So this is how we utilize a biplane ejection fractions. 4-chamber view, end diastole, end systole, 2-chamber view, end diastole, end systole. And this ejection fraction is called as modified Simpsons. Why do you say modified Simpsons biplane view is? Because every part of this ejection fraction is divided into a diskettes. And then diskette volume is taken individually and then added up sum together to give you a modified Simpsons biplane ejection fraction. Many of you can ask me, why the 2 planes in ejection fractions? Why not 1? Look, we are cutting a LV cavity in 1 slice. So if suppose this is the whole volume of a segment is, we are just doing, like I always recommend the fashion is, like you take an egg, let it stand up together, and then cut the egg in 1 section. That is a 4-chamber view. Then you rotate that egg and cut the egg in 90-degree angle. That be a 2-chamber view. So then you calculate the ejection volumes of those 2 eggs in cut in the 4-chamber and 2-chamber, and average of these 2 will give you a biplane modified Simpson ejection fraction in 2024, which is recommended as on today in clinical practice. I would like to say 2 words over here. One is the biplane ejection fraction is close to a calculated ejection fraction by MRI or 3-dimensional echo. And MRI is a gold line for calculating ejection fraction is where the three-dimension ejection fraction is much better than two dimensions biplane ejection fractions. But whatever we have read in the literature, what is promoted in the guidelines, that's what we use in day-to-day practice. This recommends biplane modified Simpson ejection fraction, male more than 52 and females more than 54. Now, segments of wall motion abnormalities. And I'm sure this is getting repeated again and again. I do use 16 segment model in my clinical practice. I told you the reason why. Because the 16 segment model is being still depicted in majority of the machines. If I change the nomenclature based on 17 segment model, then majority of machines, they are given up because they do not correlate what the ejection fraction the segments are. In four-chamber view, we have basal septum, mid septum, and apical septum. Apical lateral, mid lateral, and a basal lateral. In two-chamber view, this is anterior wall, this is inferior wall. Based on the insertion of papillary in the mid segment, this is basal, mid, and apical anterior wall. And based on the insertion of this papillary muscle over here, this is basal, mid, and apical inferior. Remember, in four-chamber view, we have a lateral papillary muscle. In two-chamber view, with inferior wall, we have got the medial papillary muscles. And if you let this picture stand up, is lying down, let the picture stand up. This is what the basal anterior septum, this is basal mid anterior septum, this is basal posterior wall, this is mid posterior. So in gist, if you look at the 16 segment model is mid and basal septum, mid and basal septum, mid and basal inferior wall is supplied by RCA. Mid and basal posterior wall, mid and basal lateral wall, mid and basal posterior wall are supplied by circumflex, and rest all segments are supplied by LAD. This is another nomenclature which is quite good and correlating with the cardiac MRI is. If you want to adopt this segment model, this is also fairly acceptable. I don't say that is wrong. Only thing is what has happened over here is, if you look at this segmental model is, this is apical cap. This is apical septum, this is apical lateral wall. So nothing has changed as far as the apex is concerned. Look at a two-chamber view, apical inferior wall, apical anterior wall. So as far as the apical septum, apical lateral, apical inferior, apical anterior wall is concerned, nothing has changed in this particular phenomenon over here. However, the mid and basal septum have become mid-inferior septum, basal inferior septum. And lateral wall has become mid-anterolateral and basal anterolateral. Similarly, in two-chamber view, is we have apical inferior, mid-inferior, basal inferior. So nothing has changed over here. Only thing is apical anterior, mid-anterior, and basal anterior segment. So these remains as such, no change as far as two-chamber view is concerned. Now, the three-chamber view has got basal anterior septum, mid-anterior septum, and apical septum. And posterior lateral wall, posterior wall has become infralateral and basal infralateral. And this is an apical capus. But it is quite interesting to remember all these kind of a thing. We have anterior, we have inferior. We have anteroseptal and infralateral. In between this anteroseptal, this anterior wall. And here is a lateral wall. So this segment become anterolateral. In between the anteroseptal and inferior wall, this segment become infroseptal. So what remembers, clearly you can remember it. This is three-chamber view where we say basal and mid-anterior septum and mid and basal posterior wall. This is called as, in this particular segment is mid and basal anterior septum, mid and basal infralateral wall. So we have two-chamber and four chambers, similarly looking at this ejection fraction. Next comes to the coronary artery supply of these valves. Why coronary artery is important in this subset of population is because if you have a significant abnormality of one coronary artery, you can really realize which segment of the valve is wall is deficit or not contracting. So apical septum, apical lateral, apical inferior, apical anterior is supplied by LAD. Median basal septum, median basal inferior wall is supplied by RCA. Median basal lateral, median basal posterior wall is supplied by circumflex. And now there's some amount of ambiguity in this. This is all dependent. LAD remains the same. Look at the LAD, nothing much is going to change. But if you are looking at the RCA versus circumflex, we have this branch of RCA and here is a branch of circumflex. So the whether is the RCA give rise to posterior descending artery or the circumflex give rise to posterior descending artery, that's what will decide the future of this median basal septum, median basal inferior wall. Similarly, it will decide the future of median basal lateral wall, median basal posterior wall, and depending on this posterior descending artery. Next comes LA volume measurements. This is what is very useful as of today in the clinical practice, measurement of LA volumes. What do? Here is, we calculate ejection fraction when the LV was fully dilated during diastole. When LV was fully shortened during systole, then we calculate end diastolic and systolic volumes. Here is, we look at an LA size, both in 4-chamber as well as 2-chamber view. When is the LA maximum size? At the beginning of what? Diastole. So LA is maximum size during beginning of diastole. So we take a 4-chamber view, we take a 2-chamber view, and we do the same thing what we did in LV calculation. We start with one annulus, go around, trace the endocardial border along, and bring back to the lateral annulus. Let the line join by itself. Then we do the same thing in 2-chamber view. We start with basal inferior segment, go along all the round, and come down to the basal post anterior wall, and let the line join. So this is area 1 and area 2. Now out of this area 1 and area 2, we have to look which is of these shorter length is. And what if the shorter length, LA volume will come up automatically. And that LA volume is not an indexed LA volume. That is the LA volume of absolute LA volumes. And if to get in the indexed LA volumes is, we have to go back and divide that into a body surface. So here is a calculation of one patient. We calculated the LA volume on one side over here, area 2 over here. And then we looked whether this segment is long or this segment is long. We thought this is small segment is, this length is shorter of these two lengths. We have to take for further measurement. So LA volume is 0.85 into area 1 into area 2 divided by shorter of these two lengths. Here the LA volume is 20.2. 0.85 into 20.2. Here is 26.6 and the shortest length is 6.74 versus 6.15. So we took divided by 6.15, they'll give you 74 ml of LA volumes. And this 74 ml, and it divide by body surface area, it gives you a 42 ml per meter body surface area of the indexed LA volumes. One more thing over here. If you calculate an LA volume is, you should not get into the pulmonic veins. 2, the most important thing is the measurement of this area and this area should not have a difference of more than 10%. Suppose this is 20, it should not be more than 22. So now if it's more than 22, then we have to go back and again calculate the LA volumes. Again, LA volumes are normal up to 34 millimeters per 34 ml per meter body surface area. And is anything more than 34 is considered as mild, moderate, or severely elevated. Same whether male or female, more than 34 is considered as normal. Give me a break for a second. Just let me pick up a cup of glass of water and I'll be back in a second. So the next part of this measurement is RV free wall thickness. Where do we measure the RV wall thickness? We go to subcostal window. In subcostal window, we look at the opening of the tricuspid valve leaflets, and wherever the tricuspid valve leaflet opens up, that is a place to measure your RV free wall thickness. And mind my words, it should always be during diastole, not during systole. Anything more than 5 millimeter is considered as RV hypertrophy. And this thing needs to be seen definitely in cases who have got a pulmonic stenosis, patient having anything to do with the right ventricular hypertrophy. Next measurement is RV-RA measurements. We go to the maximum size of RV in focused RV-RA view. What do you mean by focused RV-RA view is we go one space up instead of fifth intercostal space, we go to the fourth intercostal space. To some extent, we get rid of LV-LA. And then we look for dimensions of basal dimensions at the level of annulus, then length from the apex to the center of this basal dimension, and the mid-center of this particular RV. And when would the RV maximum size? RV would be the maximum size, beginning of systole or end diastole. So we have three measurements in this particular phenomena is we have a basal measurement, mid measurement, and the long axis measurement. Next, we go to the RA measurements. How do we look for RA measurements? Is we go for a short axis view in RA, a sub-focused RV-RA view, and then now beginning of diastole or end systole, we look at the RA measurement, which is the maximum size. We go to the annulus level, center of the annulus, we go to all the way to superior surface of RA, and the center of this, we draw another line. So this is long axis and this is short axis. RV measurements are always taken as absolute measurements, but RA measurements are always taken as index measurement. Whatever the measurement we do in RA with long axis or short axis, they have to be divided by the body surface area. So RV dimensions are 83 into 47 millimeter maximum in size. So length has to be 59 to 83, 19 and 35 the basal segments. Mid segment length is 59 to 83, mid segment 19 to 35, and the basal segment is 25 to 41. RA dimensions, long axis dimensions is 46 into 4020, which is measured over here, but maximum is 25 into 19 millimeter per meter body surface area. And similarly, we can calculate the RA volumes also, both in systole as well as diastole. We just do the same thing what we did in LV volume or LA volumes. Look at the maximum size of RA. Start with the lateral annulus or RV free wall annulus. Trace along with the endocardial, trace with the border of the LA, RA, and then come back to the medial annulus. Let the line join by itself and draw a central line. They'll give you the RA volumes. 25 plus minus 7 per meter square is the maximum in males, and 21 plus minus 6 is maximum in females. Many of you will ask me, why do you want to calculate RV-RA volume? RA is very important in COPD patients. The first segment which dilates in RA is a short axis dimension. RV is very important. Suppose you have got a pulmonary embolism, the RV starts dilating. So you need to understand whether my RV is dilated or RA is dilated or not. But the most important thing comes when you look after therapy. Suppose you had a pulmonary embolism and thrombolize the patient. What happened to my RV-RA size? Has they reduced or they're the same? So many utilization of this RV-RA size in clinical practices. Next is RV-OT dimensions. We go to parachute short axis view at aorta. So first measurement is this is proximal RVOT and this is a distal RVOT, and here is a pulmonic artery. RVOT, proximal, whether you measure in parasimal short axis view at aorta or you measure in parasimal long axis view, both the RVOT dimensions has to be less than 35 or 37 millimeter in size. So this is proximal RVOT again. So anything less than more than 35 millimeters in size is considered as dilated RVOT, proximal dilated RVOT. Similarly, we look at a distal RVOT over here, and this distal RVOT is almost corresponding to LVOT, because once you have RVOT dimensions, you can calculate the stroke volume across RVOT in this patient. So we measure both RVOT, which tells you about dilatation, and RVOT distal, which helps you in calculating the stroke volume across pulmonic valves. Next word comes vena contracta. I'm shifting my image from a basic two dimensions measurements to now Dopplers. And what I do in this subset of population is I'll switch over my gears and take out another segment of populations to talk about the vena contracta. Give me some time. I'll switch over and come back to this vena contracta. Here is LV mass. The LV mass is calculated by two methods in day-to-day practice at your level. We go to parasternal short axis view at papillary muscle, do a cut section across it, then trace this LV from beginning of this interventricular septum, end of this interventricular septum, then left ventricular internal dimensions during diastole, then posterior wall dimension during diastole. Similarly, at the end of a systole, we look at the interventricular septum during systole and the posterior wall during systole, and this gives you values of LV mass by two dimensions echocardiography. Then we calculate one important thing is relative wall thickness. What is relative wall thickness? Relative wall thickness is 2 into posterior wall thickness. Look, what is the posterior wall thickness? Is over 10 millimeters in size. 2 into posterior wall thickness divided by the left ventricular internal dimensions during diastole. So if this is 2 into 10, that is 20. And if it's 40, so 20 divided by 40 will give you the relative wall thickness. And the machine itself give you, when you do this, it'll give you the LV mass. So we have a relative wall thickness. We have an LV mass. Based on this, what we come to a conclusion is we talk of concentric hypertrophy, eccentric hypertrophy, and a concentric remodeling. Normal person will have relative wall thickness of less than 0.42 with a LV mass in females less than 95, males less than 115 grams per meter square body surface area. If that is true, we call them as normal geometry. If it's more than 42 and the mass is more than 95 and more than 115, we call them as concentric hypertrophy. On the other hand, if it's more than 42, but the volume of mass is less, we say concentric remodeling. If this dimension RWT is less than 0.42 and the mass is more than 95 and 115, we call them as eccentric hypertrophy. Many of you can ask me what is the importance of this concentric, remodeling, hypertrophy, eccentric hypertrophy. Well, these are the numerical values which tells you in what direction my hypertrophy is going on. And when we correct these hypertensive hypertrophies, they start regressing back to the normal states with your adequate management of hypertension and control of blood pressure. But that is what is recommended by two-dimensional echo. Everybody has got two-dimensional echo, but the best method of calculating LV mass is by 3D echo. And this 3D echo, I'm sure not at your level. What we do, this is more of a research work where we calculate 3D LV volume, mass, and then which is very comparable to cardiac MRI. And that's why we use number of times this research tools where we look at an LV mass in different conditions. Moving on further, apart from LV mass, we have aorta measurements. At your level, what we talk of is this is LVOT dimensions at the level of annulus. Then we have sinus venosus or sinus of Valsalva. What we have is the right sinus of Valsalva versus non-sinus of Valsalva. So at the level of sinus of Valsalva, and where the sinus of Valsalva ends, this is known as sinotubular junction and followed by ascending. So at your level, I'd like to say like just measure LVOT dimensions, and that's all is required for a basic level to talk of aorta or root dimensions. Before I switch on to a Doppler measurement, kindly raise your hand so that I'm able to explain you anything which is left in this particular phenomenon. Any questions? They can raise your hands. Dr. Neeraj Dodke.
Hello.
Go ahead, Neeraj.
Sir, in the while calculating in the M mode, we calculate from leading edge to leading edge. No?
Correct.
Sir, can you please go to that slide in the last one? Yes. No, sir, the LV mass slide. LV mass.
So if this is an LV mass for calculation of LV
Yes.
masses, we
Sir,
start from the first edge of this interventricular septum.
But sir, in here the arrow is showing from the trailing edge to leading edge.
This is wrong. We're showing something different. We have picked up this. We have picked up the internal dimensions during LV dimensions. This is shown not the correct method of showing what we wanted to show.
Okay.
This should be starting from here and over here, then goes down to posterior wall and then the posterior.
So while calculating, sir, we go from the leading edge to the trailing edge of the
M mode always leading edge to leading edge.
Yes. Okay. And in systole also from the leading edge to the leading edge.
Always.
Sir, how exactly we do it? Will it be told afterwards or
I'll
like?
be showing you live demonstration. Just give us some time.
Okay. Thank you, sir.
Dr. Ripan. Go ahead, Dr. Ripan.
Sir, please explain M1 measurement of left ventricle in plex mode, in plex view.
Okay. This is plex view at the level of aortic valves. This is RV, this is anterior aortic root, this is posterior aortic root, this is LA. So once we cut over here, what we get is first we get RV, OT during diastole, this is and systole. So we get RVOT dimension during diastole. Then we get from leading edge to leading edge for aorta, then leading edge to leading edge of LA, and then aortic valve opening from a leading edge of aortic valve opening to the leading edge of aortic valve. That's how we get this particular dimensions of. The same thing we do it is in moving the cursor. If you happen to move this cursor from aorta to the tip of the mitral valve leaflets, so what you will get? You will get the mitral valve opening and closing. And this is E point septal separations, where the E point is over here, where the mitral valve is opened up. This is interventricular septum. And whenever the LV dilates, look at this tip of the mitral valve leaflets. Whenever the LV dilates, this becomes dilated. It's more than 7 millimeter in size. So it's 2.2. It means LV is dilated. Now move this cursor just distal to the tip of the mitral valve leaflet. What you will be cutting is a basal anterior septum and basal posterior wall. And once you're cutting a basal anterior septum and basal posterior wall, what you'll get? You will get this kind of a picture. Don't look at this picture on this side. You will get something like this kind of a picture where you see interventricular septum, anterior septum, and the posterior wall over here. And then you can measure the M mode measurements. I'm going to show you live in next or next to next class. The same thing.
Thank you. Thank you.
Dr. Nitin Parekh, and go ahead.
Sir, I just want to confirm that papillary muscles will be present on inferior wall and lateral wall, correct?
Correct.
Okay, sir. Thank you, sir.
Dr. Shekhar Chakravarti.
How can we differentiate posterior LV wall from the pericardium?
Okay.
And in your discussion of LA volume measurement, that is you may 0.85 into A1 into A2 divided by L, and 6.15 is how this figure comes.
Okay.
These two questions.
Let's start with pericardium. Look, LV wall thickness will have a contraction. Look, LV wall thickness has got a contraction over here. Can you see this contraction?
Yes.
Second thing is, it's not the only it's the endocardium and myocardium which thickens over a period of time.
Yes.
So what we look is a thickening of this endocardium, which will give you a difference. Now, where's the posterior wall? Posterior wall is when you see it. Look at this separation over the wall over here. Behind them is a posterior wall. Another way of looking at this pericardium versus LV wall thickness is how to differentiate is reduce your gain completely. Once you reduce your gain completely, this myocardium or endocardium will disappear and you'll only see a pericardium.
Okay.
One. Second is your LA volumes. Your question in calculating LA volumes is, where do we get that?
Bad.
My humble request to all of you, please silent your mics. Otherwise, what will happen tomorrow, don't feel at the time, the person who's sitting on the IT side will shunt you out completely. My folded hand request is please silent your mics. That's all I'll say again and again. Like somebody, Dr. Sheetal Shinde, she's just shouting on a mic. And her mic is wide open. We are here to listen. Look, somebody who comes and prepare and present this talk, it takes a lot of time for somebody to come and prepare and deliver the topics. And our request is please, for God's sake, let the speaker deliver his talk properly. That's all I'm going to say is, and gradually we'll move on to international speakers. And when we move on to international speakers, those people, they feel very bad. Their mics are not silent. So please do not give this impression to international speakers. Look, their mic is always open. So next question of Dr. Shekhar Chakravarti is, how do you get an LA volume and what is this dimension is? Look, what LA volume is, I said the 0.85 into area 1 into area 2. So we are sure how to calculate the area of the LA. Then these two things have got a length. One length over here is 6.74. The second length over is 6.15. So this is one length over here. This is one length over here. Which length we have to choose? We'll choose the shorter of these two lengths. 6.15 is shorter than 6.74. So LA volume is 0.85 into area 1, that is 20.2, into area 2, 26.6, divided by 6.15, that gives you absolute LA volumes. Divide this LA volume by body surface area, you will get indexed LA volume. Anything more than 34 is considered as abnormal.
Okay. So we have to take the shortest volume of the
Correct.
LA.
Not shortest, the shortest length.
Shortest
Volume
length, right.
Volume is the same, but we have to take a shortest length.
Thank you, sir.
Right. So Dr. Yogesh Hazmera,
Good evening, sir.
Good evening.
Uh, Sir, while measuring ejection fraction in four-chamber view, I'm finding it difficult to exactly locate the apical border of the left ventricle, sir. Is there any specific way to identify apical border? What exactly is the
Very common
point?
thing which happens with the beginners. The best answer is go to sixth intercostal space instead of fifth. Ask the patient to take a deep breath. Your LV will become absolutely clear. Apex will become absolutely clear. Let the patient take a deep breath. Hold his breath. And you will see a beautiful LV in that patient where apex would be clearly seen.
Okay. Thank you, sir.
Right. Dr. Harsh Kachela.
Good evening, sir.
Good evening.
My question is if you take the LV dimensions from the M mode and when the LV dimension with the Plex mode, so which will be much more accurate as compared to both?
LV dimension by M mode, LV dimension in Plex mode. I did not understand your question.
For example, if we cut the by M mode, if we cut in the this short axis mitral valve, sorry, short axis mitral valve level, if we cut this by M mode and as compared in the Plex mode.
Okay.
So okay.
Now I'll give you an answer. In 2024, if somebody asks you to measure your LV dimensions, this should be your method of calculating LV dimensions. Plex window, basal anterior septum, basal posterior, just distal to the tip of the mitral leaflets. And lastly, end system. So in 2024, if you ask me to calculate LV dimensions, I'm going to do this and I'm going to do this.
Okay. Thank you, sir.
That's the most accurate. Okay. Dr. Anil.
Sir, the diagram given in book at the page number 15, para-external long axis view. I couldn't understand some of the abbreviations, sir. Those are ARV, LS, PPM, RS, EN, and PLA.
Just send it on WhatsApp. I'll reply on a WhatsApp.
Okay,
I don't have a book right now with me. Just send on a WhatsApp. I'll reply you.
Okay, sir.
Dr. Neeraj Dotke.
Hello.
Go ahead, Neeraj.
Sir, my question is how to optimize the apical four-chamber view, because sometimes it becomes slant, sometimes it is not in the vertical.
Yeah, it's a good question, Neeraj. Like optimization of your apical four-chamber view is, my submission is, you feel the apex beat first.
Okay.
Put your transducer as parallel to the image or heart as possible. And now, if you look at this image, I'm going to go to that image. So, no, I'll not take this. This is what we are doing is, if you happen to see a good LV cavity and a small RV cavity, that is normal, correct?
Okay.
Suppose you see a large RV cavity and a small LV cavity, it means you are in fourth intercostal space. Why do you? Because from apex, you have moved towards the mediastinum. So you'll see better RVRA as compared to better LVL. So in your case, if you have a problem with doing a good echocardiography apical window is, first of all, feel the apex beat, put your transducers as parallel to the heart as possible. And then second is, once you get the image, like I told you, right and left. Suppose you see more of a right, then you go a space down. If you say more of a left, it means you go up a space up. And then bring down your cursor almost to the apex, to the center of this image. And the best answer I can always give you, to begin with, go to sixth intercostal space, ask the patient to take a deep breath. Hold it. Though he'll not be able to hold for a long time, ask him to hold it for a couple seconds, whatever, 20, 30 seconds he can hold it. Then you can acquire the best four chamber. Okay. And it'll come with the practice over a period of time. It will not be available immediately.
So my next question is how to remember the blood supply in those segments, because
How old are you, man?
yeah, sir.
How old are you?
I'm 33, sir.
Okay. So I can talk of Dr. Multani sitting over here is Dr. Multani, you had remember those time when the picture tickets of the picture hall used to have a blacks. Like the ticket of 2 rupees was sold at the level of 6 rupees. So what do you used to say? Do ka che, do ka che, do ka che, do ka che, 226, 226, 226. So the best answer to remember the blood supply is one of you should say mid and basal septum, others guy should say mid and basal inferior wall, the third person should say RCA, 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 RCA. Mid and basal septum, mid and basal inferior wall, RCA, 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 RCA. Mid and basal posterior wall, mid and basal lateral wall, circumflex, 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 circumflex. And the last person should say all rest, LAD, 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 LAD. So go back and remember this formula: mid and basal septum, mid and basal inferior wall, RCA, 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 RCA. Mid and basal posterior wall, mid and basal lateral wall, circumflex, 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 circumflex. Rest all LAD, 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 LAD.
Okay.
Tomorrow, going to hospital.
Yeah. The next one, just last question. Is it really necessary to remember all these measurements?
Yes. To a large extent, these measurements are important. I'll pick up one by one. I say LVOT dimensions. LVOT dimension is very useful for calculating stroke volume and aortic valve area by content equation. 2. Mitral valve area for mitral stenosis. 3. LV ejection fraction. Day-to-day example for ejection fractions. Then what? Blood supply is a very important phenomenon. LA volume, always for diastolic function evaluations. RV wall thickness, need not do in every case because whenever is needed, you can do RV wall thickness. RVRA dimensions, whenever you look at a patient who has got a dilated RVRA. Normal LVLA would be something like this. You have a small RVRA, bullet-shaped LV and triangular RV. If this triangular RV becomes bullet-shaped or becomes dilated in shape, then you concentrate on measuring your RVRA dimensions. And in Plaque's window, always spend time. This is a learning. Always spend time to look at this Plaque's window over here. Proximal RVUT dilatation will tell you, look, RV is dilated. Not in every case. Suppose I've got a mitral stenosis, I need to calculate mitral valve area by planimetry. Suppose I've got aortic stenosis, I have to look at LVOT diameter and LVOT VTI. You can separate them out, but how will you separate it out is to begin with, try to do it every subject because that will make you perfect over a period of time.
Thank you, sir.
Dr. Yogendra Deswal.
Good evening, sir.
Good evening.
Sir, my question was regarding the Simpson's method, sir, which we do for ejection fraction, sir. Like what we take, sir, when we take the area, sir, there's a slide on the other one, sir.
I'm sorry. What we take an area, this means what?
Sir, actually, my confusion, yes, sir, this slide, sir. Sir, on the right side, sir, there are a lot of papillary muscles which we can see in the myometrium, sir.
Correct. So
sir,
you include or exclude?
Yeah, correct, sir. Because in some cases, concentric LVH, sir, there's a lot of, I mean, we take from inner this thing diameter, sir, then it is a lot of high ejection fraction. If take it outside, then it becomes low. So bit confusion.
No. Always take from inside. Look, what we are talking is, we are talking of black and white interface.
Correct, sir.
This is an endocardium. This is endocardium and myocardium over here. Correct.
Sir.
So in hypertrophy, so what will happen? The LV cavity will become smaller.
Yes, sir.
Correct. So we do expect LV hypertrophy, the LV cavity has to become smaller and ejection fractions to go high. That's normal. And we write this word, look, there's a significant LV hypertrophy. So the LV volumes, look at the LV volume. I did show you LV volumes over here. Just a second. Look at the LV volumes, end-diastolic volumes, biplane method, 106 plus minus 22. So if your LV volumes have become smaller, obviously your ejection fraction would be high.
Correct, sir.
But if your LV volumes are smaller and your ejection fraction is low, it means your hypertrophic patient has gone into dysfunction.
Sir.
Correct?
Sir. Because there was a confusion, sir, whether to take like sometimes the patients which we have like post-MI patients, one wall is thinned out, other wall is thickened. So sometimes we do get erratic LV ejection.
Always measure your black and white interface. Always, always. That should be the dictum.
Right, sir. Thank you, sir.
All right, dear. Dr. Shripat Kore.
Yes. So you explain the slide of concentric and eccentric hypertrophy again.
Okay, I'll do that. Give me a second. Got it. So whenever we're talking of hypertrophy, concentric, remodeling, eccentric hypertrophy, or concentric hypertrophy, first of all, we should understand we are not going to do that in Plaques view. That's we do in parasomnic short axis view at papillary muscles, as somebody said, inferior as well as lateral wall of the papillary muscles. So we should see a good echo window and then take a cut section across this parasomnic short axis view at papillary muscles. So what we'll get? We'll get this pattern of the image out here. We calculate RWT. RWT is 2 times into measurement of posterior wall in centimeters divided by left ventricular internal dimension during diastole in centimeters. So that will give you RWT, relative wall thickness. Whenever you do the same method, the picture will give you an index LV volume by 2 dimensions echo. If you really ask me, this is not a correct method. Because what we are doing, we are just cutting at one anterior septum in the posterior wall. Correct? Yes. But we still utilize this particular phenomena. And when we do this, when we look at this, if relative wall thickness is less than 42 and mass is less than 95 and 115, we call them a normal geometry. If both of them are increased over here, just opposite that, more than 42, more than 95, 115, we call them a concentric hypertrophy. So these two things are very clear?
Yes, sir.
Question comes when the LV wall thickness is RWT is more than 42, but mass is normal. Then we say concentric remodeling. When LV wall, relative wall thickness is less than 42 and the mass is more, we say the eccentric hypertrophy.
Yes, sir. Thank you, sir. Yes, sir.
Everything is given in machine. You have to ask the vendor to open up this. Look, I want to calculate my RWT. Please put in a formula into this. Okay, so once you do this in this particular view, parasomnic short axis papillary muscle, once you get this picture, what happens? You just start measuring from this point to this point, that's posterior wall, internal septum. Then from this point to this point is left ventricular internal dimension during diastole. And then from this point to this point is posterior wall during diastole. Then go to systole, thickening of the internal septum during systole. This is what the thickness is. Then left ventricular internal dimension during systole, this from this point to this point, and the posterior wall thickness during systole. So you feed this thing in computers. Computer will give you relative wall thickness and LV mass. And then you can just look at what kind of a category this LV hypertrophy is. Clear?
Thank you. Thank you.
Okay. Anybody else? If I move on to my next very small presentation, not a large one, anything left in my Dopplers. Okay. All right. In Dopplers, what we need a basic requirement in clinical practice. That's what I'm going to talk about. we need to look at peak and mean gradients. We need to look at pressure half time. We need to look at a continuity equation, then holodynamic reversal of flow in descending aorta, and the Doppler calculations. Now, how do you see peak and mean gradients? Suppose this is a patient of mitral stenosis with a normal sinus rhythm. This is E wave, this is A wave, as we told you in the last class. Then, very simple waves, just trace this Doppler envelope. From a beginning of this Doppler envelope, go up, go along with this line of this Doppler envelope, trace it and bring it back. So what it contains all the velocity, whether high or low, during peak or mean. So machine will give you a peak velocity of 2.04, mean velocity of 1.47, peak gradient of 16.7, mean gradient of 9.3. Correct? So machine is telling you about peak and mean gradients. Now draw this line from this point to this point. This is how much time it taken from this pressure to drop to half during this line, which is known as pressure half time. 220 divided by pressure half time will give mitral valve area by pressure half time. So machine will tell you what is the area of mitral valve, what is the pressure half time is. And then at the same time, it will give you velocity time integral, which is seen over here is 49.17. How much of blood travel, how much distance of blood travel with each stroke of an LV. That is velocity time integral. So everything is given by machine. So we look at the peak gradient, we look at the mean gradient, and then pressure half time, as well as the velocity time integrals. Now, second question is, for continuity equation is, this is LVOT, this is aortic valve, and this is aorta. The concept is whatever the blood which is flowing through LVOT has to flow across aortic valve. It's a very simple phenomenon. Suppose somebody has got a society, how many people are going in? They have to go through the same inlet door and then go to the society's main gate where the apartments are there. So what are the number of people are going to the main gate? They have to go to the society's floor gate where they have to take a lift or they take a staircase to get into the building. So here is, we know in LVOT diameter we calculate by parallax view. Then we calculate LVOT VTI. How will you calculate LVOT VTI? Anybody can open their mic? By putting a sample volume at LVOT. So where do we keep a sample volume LVOT? We keep it in 3-chamber view or 5-chamber view. So we do this in sample volume in LVOT, and whenever we get a sample volume in LVOT, we, just a minute, let me show you, there is an example out here. Yeah. So this is LVOT diameter. Then we keep a sample volume in LVOT, that's pulse wave sample volume, just before the aortic valve leaflets. And then what we get, a LVOT VTI. How do we get the LVOT? We place this Doppler spectrum pattern. It'll give you a peak velocity, mean velocity, peak gradient, mean gradient, but the most important is velocity time integral. So if I take these things together and go back to the image of aortic valve area is the area of LVOT into velocity time integral at LVOT. That is what is known as stroke volume. This is the amount of blood which is going through LVOT. Now, on the other hand, if you do a continuity equation, if you do a Doppler, it will be now in 3-chamber view taking care of the LVOT as well as aortic valve area. So it will give you aortic valve VTI. So if I get this LVOT area into LVOT VTI, that is stroke volume, divided by aortic valve area and VTI. We cannot do an aortic valve area over here. So what we do is, we divide this value from aortic valve VTI to calculate aortic valve. We'll come to this again and again. At this level, you need to understand that we have to calculate stroke volume across LVOT. And that stroke volume across LVOT is LVOT diameter divided by 2 will give you radius, then pi r square. That is LVOT area. into velocity time integral will give you a stroke volume. So in this patient, look, what is LVOT diameter? 1.87. Divide this 1.87 into 2. So whatever the value is, square it off, multiplied by 3.14, they'll give you LVOT area, pi r square. Then multiply that particular value with LVOT VTI. So it'll give you aortic valve, LVOT stroke volume. Clear? So this is how we look at LVOT VTI and LVOT area to get you a stroke volume. And if you divide by aortic valve VTI, we'll get aortic valve area. This is what we see in day-to-day practice is a holodiastolic reversal of flow in descending aorta. So what is this? Like we go to suppressor window, switch on the colors, and we see a red color going back into the ascending aorta. Descending to ascending aorta or towards arch. So we put a sample volume in this descending aorta and we get a Doppler flow pattern over here. So in systole, it shows you a positive Doppler spectrum pattern because of the blood going down. And then you have a diastolic reversal, which is a holodiastolic reversal. Look, holo means through and through in diastole, right from beginning or end of one systole to beginning of other systole is. This is known as holodiastolic reversal of flow in descending. So if you happen to see holodiastolic reversal of flow, trace this Doppler spectrum pattern. Should the VTI of more than 22 and the end diastolic velocity more than 22, which is known as significant aortic regurgitation in aortic regurgitation. We did discuss the coronary artery supply. Same mid and basal septum, mid and basal inferior wall, RCA, RCA, RCA. Mid and basal posterior wall, mid and basal lateral wall. This is mid and basal lateral wall, mid and basal posterior wall. Circumflex, circumflex, circumflex. Rest all is LED, LED, LED. The question of showing this slide is, look, if you look at this slide very carefully, this supply is basal, mid, and apical segments. What do you mean by mid segment? Mid segment is a segment where the papillary muscles are present. So if I cut this segment over here, it'll be cutting over here, it'll be cutting over here, it'll be cutting over here. Right? So if I cut my mid segments, it'll be cutting mid septum, mid lateral, mid inferior, mid anterior, mid posterior wall, mid anterior septum. So what we'll be looking for? 1, 2, 3, 4, 5, 6 of our segments. And we can look at this mid segment in short axis view, parasolic short axis view at papillary muscles. So here is the papillary muscles. So this is the mid segment. I look at this mid segment is lateral wall. This is septum. Opposite septum is what? What is opposite to septum? Lateral wall. Anterior wall, inferior wall. And then anterior septum as well as the posterior wall. So we have 6 segments over here in mid. If you go to the apex, we do not have any segment nomenclature for the apex. We have apical, inferior, apical anterior, apical septum, apical lateral. So anterior, inferior, septum, and lateral. And if you go to the bases where the papillary mitral valve is present, we have basal septum, basal septum, and basal lateral wall. Basal septum and basal lateral wall. Then basal inferior, basal posterior, anterior wall, and then basal posterior wall, and mid anterior, basal anterior septum. So this is how these cut sections are dried. And this gives you a very good LV contraction. If you, this is parallel and this is perpendicular for the images. So that's what I like to stop it over here. And I know it's quite difficult to remember all these things in one go in 2 hours time, which is a Herculean task. Even if you ask me to remember all these things, I'm not going to do that at any cost. I have to do it again and again. And what I suggest always is, if you happen to start doing echocardiography, print this out. Get it laminated based on your walls. Similarly, print this out measurements, various measurements which I've told you. Then get them laminated and paste in your walls. So maybe your Aqua lab have got so many printed and posted signs, symptoms on the walls. What we do, we keep them in our table, on a reporting table, where we do a routine echo reportings. And those laminated paper are always there for ready references. Next important thing is our book is also for a ready reference majority of times. I'm sure by the time this group will finish, we have another edition ready for you to read. So we are in the process of writing or updating this book with the newer guidelines in a time to come. So I'll stop over here. Any questions I would love to take for Doppler spectrum pattern? Dr. Shilpat Kore, go ahead.
Sir, there is one confusion in which part of systole or diastole we should take the measurement for aortic LVOT and LA. That is some amount of confusion to me.
Okay, don't get confused. When is the LVOT maximum in size?
At the
when the LVOT or aortic valve leaflets will open? During diastole or systole?
Systole.
Correct. So we do LVOT measurement with early systole.
Okay.
When you look at this picture, I showed you this picture. LVOT dimensions when the both leaflets are open of one over here, one over here.
Yes.
So early systole, these two leaflets will open up. So where you will measure your LVOT dimensions. Now, when would be the LA back maximum size?
End of diastole.
End of systole.
Yes. End of diastole.
End of diastole will be smaller.
Okay.
End of systole.
Yes.
Now, when this aortic valve is open, it's pushing blood into the from LV to aorta. Meanwhile, LA is receiving blood from pulmonic veins, and this mitral valve is open or closed. Once this aorta closes, aortic valve closes, then only this mitral valve open. So when this mitral valve open is when the end of a systole or beginning of diastole.
Yes.
Now next question is when is systole, when is diastole in ECG? Beginning of QRS complex to end of T wave is systole. Beginning of end of T wave to beginning of QRS complex is diastole.
Yes.
Okay?
Yes. Thank you.
Right there. Gunchan Walsange.
Good evening, sir. Sir,
Good
what
evening.
is EPSs? There was one slide, and the initial slide you had shown the measurements we have to look into.
EPSs?
Yeah.
This is EPSs is E point septal. Look, in my previous slide, where my cursor was, the cursor was at the aortic valve leaflet. Then I moved this cursor at the tip of the mitral valve leaflet. So what happened? Once I moved this cursor to tip of the mitral valve, this is opening of the mitral valve. This is known as DE excursion and then EF slope. So this E point and S is E point septal separation. This has got a very good value. Like majority of people, they do not use it anymore, but still I use it number of times. Whenever I suspect LV is dilated, believe my word, this is the most sensitive parameter which I always find.
Yes,
this is normally 7 millimeter.
okay.
Anything more than 7 millimeter is considered as dilated. How do you say in my life, like, what is this E point septal separation? Look, if you look at me, like, apex is always fixed, and the base, which moves, like mitral valve, moves towards an apex. That's how the heart moves. Correct. So when apex is fixed, the base moves. Where do we dilate? In the mid segment.
Yes.
This is mid segment dilatation. If I compare this to a human being, when we are fully grown up, where do we dilate?
In the trunk.
Belly. So this is
Yeah.
belly of a human being, which tells you my LV is dilated.
Okay. Yes. Thank you, sir.
Right. Anybody else? Dr. Adnan Bashar. Neeraj Jodhke, go ahead.
Yes.
Adnan, any question?
Actually, I had a question regarding EPSS, which is being answered
Wow,
you
great,
previously.
great. So you
Thank
have a EPSS smaller or larger?
It is EPSS larger 21. So this picture
No, I'm not asking
signifies
this
that.
picture EPSS. I'm talking about your EPSS.
Oh, my EPSS is seems to be normal, I think, as because I didn't did echocardiography recently, but myself of mine. So I think it's normal.
No, I'm talking about your belly, man. I'm not talking your EPSS.
Yes, it's less than 7, I think.
Okay, I'm fine. Great. All right,
Thank
great. Dr. Neeraj, go ahead.
Sir, can you please show the slide of calculation of aortic valve area once again?
Aortic valve. Okay. So what we need in aortic valve area is we need an LVOT diameter, correct?
Yes.
So diameter divided by 2 will give you radius. Pi r square is an area. So this LVOT will get an area by pi r square. If I multiply this LVOT area by LVOT VTI as shown in the next slide by LVOT VTI, then I get an LVOT stroke volume. Correct?
Yes.
So whatever the blood which is flowing through LVOT has to flow through aortic valve.
Yes.
But I do not have an aortic valve area because in aortic stenosis, what you need? You need an aortic valve area.
Yes.
But at the same time, instead of pulse wave Doppler, in this particular format, if I switch over to continuous wave Doppler, they will be calculating blood across LVOT and aortic valve also.
Yes.
So by continuous wave Doppler, what I'll get? I'll get aortic valve VTI.
Okay. So we have to shift to continuous wave Doppler.
You have to shift to continuous wave Doppler obviously, because whatever the blood which is flowing through LVOT has to flow through aortic valve.
Yes.
So switch over to continuous wave Doppler to look at aortic valve VTI.
For LVOT VTA, we have to do the sample volume with the pulse wave.
Because this is site specific.
Yes. Okay.
Here there's nothing like site. If I move this pulse wave sample into aortic valve, what will happen? Aortic valve has got a very large velocity. Yeah. So what I need then is to contain the Doppler spectrum pattern, it'll show aliasing. Look, the sample volume will be over here, go to other side. Yeah. So what I'll do, I'll take this baseline up, increase the scale, but the velocity is still more. So what do? I switch over to continuous wave Doppler.
Okay. So another question is, like, when you say that we have to decrease the gain or increase the gain, it might be a very basic question, but how to do that and what do we get from it?
Gains of 2D image or gains of color?
The gains of 2D image.
2D image gains. Look, if you look carefully in this image over here is, this cavity has nothing, no structure in this cavity.
Yes.
So, but it's still showing some white speckles in this cavity. More over here. More over here. Yes. So it means its 2D gains are high. So we try to reduce the 2D gains so that we see a black cavity over here and white interface over here. Okay. So this is over gains. Correct. Now look at this Doppler. The Doppler gains are on a higher side. Why the Doppler gains are on higher side? Look, ये आपको ये बाल दिखाई दे रही है, दाढ़ी दिखाई दे रही है.
Yes, yes.
So this daढ़ी should not be seen.
Okay.
It should be clean out here.
Okay. So by increasing the gains, we mean that the contrast is high.
Contrast is high.
So we need that. No?
We need that, but at the same time,
for
we
better
want
visualization.
extra gains also. So we need to reduce these gains. I'll
So
be
when
showing
we-
this. Try to remember these things when I'm showing a live demonstration. I'll try to show all these things.
Okay. Okay. So just one more thing, sir. I need to clear it up. When we increase the contrast, the gains are high. Hello.
When we increase the contrast, no, I don't say that. When we increase the gains of a 2D, increase the gains, this kind of a picture will appear. Similarly, when we're doing a Doppler, increase the gains, this type of picture will appear. And moreover, we have some low flow filters, low velocity filters also. I'll
by
show you those kind of a things when I show live, because I can't describe in words.
Okay, sir. Sir, one more thing. You were talking about vena contracta. So
It'll come when we talk of a Doppler, when we come of mitral flow regurgitations.
okay. Thank you.
Dr. Salman Beg.
Hello, sir.
Go ahead, Salman.
So you said that EPSS indicates the LV dilatation. Does it have any say on EF also, or it's just the dilatation?
Obviously, whenever the LV will dilate, is bound to affect the ejection fraction, but not always.
Yes, sir. Like mitral regurgitation and all. Will be
Like in mitral regurgitation, LV will dilate. It'll show hypercontractility to begin with.
Yes, sir.
But over a period of time, despite dilated LV, the LV fraction, ejection fraction starts falling down.
Okay. Okay.
Suspicious of dilated LV may be leading to a less ejection fraction, but not definitely.
Sure.
It tells you, it guides you.
Yes, sir. Thank you, sir.
Dr. Sharmin.
Good evening, sir.
Good evening.
When calculating the aortic valve area by continuity equation, I faced some problem placing the PW in the sample volume. I got aliasing.
Good question. What she's saying is, if I put my sample volume in the pulse wave into the LVOT, I get aliasing. Correct? But why you get
Yes,
aliasing?
sir.
Because you're closer to.
Why I am getting? Okay, sir.
So that's why a couple of people, what do they say? We should not measure LVOT at the level of annulus. This is annulus, in fact. We should go 2 to 3 millimeter or 2 to 5 millimeters into the LVOT, same anteriorly,
okay, sir.
posteriorly, then draw a line. That is the LVOT true. So in case you are getting aliasing in LVOT, just go back into the LV cavity, slightly towards LV cavity.
Thank you, sir.
Right. Dr. Somnath.
Hello.
Go ahead, Dr. Somnath.
So can you just enumerate or summarize the basic all AM mode measurements that are required, in which echo window to take that, and at what stage of the cardiac cycle to take those?
All right. No
just
issues.
to summarize.
Aorta AV cusp separations in parasonnal long axis view at aorta. Aortic valve measurement at the beginning of systole. Same AV cusp separation at the beginning of systole. Then LA measurement in beginning of diastole. Then next point is E point septal separation when during diastole, when the mitral valve is opened up, Plaque's window. Third is LV dimensions, diastole as well as systole. That is 2 dimensions, 2D dimensions of LV. Similarly, LA dimensions during and systole when LA is biggest in size. LVOT dimensions, flax window when both the leaflets are open up, early systole. Mitral area in early diastole when the mitral leaflets are fully opened up. Ejection fraction, best answer is go to 6 intercostal space, ask the patient to take breath, and then you can see a clear-cut LV apex. So this trace the endocardial during diastole as well as systole, and diastolic volume minus end systolic volume divided by end diastolic volume into 100 will give you ejection fraction. LA measurements always during end diastole, so end systole, beginning of a diastole when LA is maximum size. 0.85 into area 1 into area 2 and shorter of these two lengths will give you LA volume absolute value. Divide by body surface area will give you indexed LA volumes. RV wall thickness during diastole at the level of tricuspid valve opening, anything less than 5 millimeter. RV dimensions, dilated RV fully opened up end diastole when the systole is about to begin with long axis at the level of annulus and mid segment. RA and systole maximum for diastole when the tricuspid valve is about to open, annulus, long axis and short axis dimensions. RVOT, proximal RVOT, passing short axis view at aorta as well as flax window. Distal RVOT at the level of tricuspid pulmonic valve leaflets. So these are the all measurements what we do in day-to-day practice. Dr. Neeraj Dotke, go ahead.
Sir, what does the RV free wall thickness indicate, less or more?
Well, this is a formula which has been created by learners or researchers in echocardiography. The rate RWT thickness, they just wanted to emphasize whether this thickness is more or less. And that's one of the constant phenomena they describe about it. I have to really look at in the literature what is RW thickness, how this has been decided. I'll have to really look.
No, sir, the RV free wall thickness.
RV free wall thickness for what?
So if it is more than 5 mm, then what does it indicate?
Oh, RV free wall thickness more than 5 millimeters, RV is hypertrophic.
And if it is less than 5 mm, then?
Normal.
Normal.
Adnan Bashar?
Sir, I have a question that what should be the ideal sweep speed during the measurement of VTI?
Per second.
Thank you.
Dr. Muhammad Masudar Rahman.
Good evening, sir. Sir, during measurement of interventricular septal thickness or left ventricular wall septal thickness, should we include endocardium or not?
Good question. When do we see a thickening of endocardium, during diastole or systole?
Diastole, sir.
When do you see a thickening of endocardium, during diastole or systole? Thickening of endocardium is seen in systole. So
yes,
we measure our dimensions during diastole and we see just a minimal like line kind of a structure during diastole of endocardial thickness. So we do include, let me go back to this picture again. Look, this is a line which you see over here, correct? This is all myocardium. And when endocardial thickens, this becomes more. It's not the myocardium which thickens, it's basically endocardial thickening happens. So we do include the tip or the basis of myocardium. That is what the black and white interface with the myocardium. That's what somebody asked you. How do you differentiate with myocardium with pericardium? So here is I can show you. Look over here. What is this structure seen over here? Can you see the structure over here? Let me zoom up for you. Now, can you see this structure over here? Wait a minute. Do you see this? What is this?
Endocardium.
Correct. So it's a very small, thin line over here. And if you see very carefully, then only seen. And this is like we have zoomed up the picture. If you really look at the endocardium, this is a very magnified image. So what we do not measure this endocardium and myocardium. We cannot differentiate them. These are very small, thin lines. Okay. Anybody else? Don't find anybody on the question list. Dr. Shekhar Chakravarti, any questions from your side?
No, sir, thank you very much.
Okay.
We enjoyed the class.
Thank you. That's all. Shall I stop it over here?
Yes. Thank you.
Okay, sir. Okay, thank you.
Right. Thank you. Let's stop the presentation over here.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, everybody. Thank you very much.
you, sir.
We see you next week. Stay safe. And
sir.
next time, meet again.
Thank you, sir.
Bye-bye. Good night.
Thank you, sir.
Thank you. Good night, sir.